So let's take 25 minutes and talk about medications for cardiac CT and the basics of acquisition that lead to good outcomes for our patients. And then we'll open up for questions, all right? There are almost 15 randomized controlled trials of cardiac CT. The most recent one is this one from the New England Journal of Medicine from 2 years ago that looked at coronary CT and the results on 5-year outcomes of the patients and showed that if you follow patients who have a cardiac CT over the following 5 years, they have a 40% reduction in death or myocardial infarction following cardiac CT versus stress testing. So our goal in the hospital setting and outpatient setting is to reduce the rate of death and myocardial infarction. So this is good. And this is compared to the standard of care, which is stress testing. And this is driven by a lot of different factors. One of those is cardiac CT is more sensitive, so it finds more patients that require stents and bypass surgery, whereas nuclear stress test misses people. So the benefit is seen in the first 50 days after the test. And then that benefit is sustained over 5 years based on increase in preventative therapies after the revascularization and the increase in behavioral changes that people see after cardiac CT. The same benefits are shown in the emergency department. So in randomized trials, there's almost 15 randomized trials in the ER. Same benefits are seen. The patients will have a reduced rate of death and MI, major adverse cardiac events from a coronary CT versus stress testing. Now, how does this benefit occur if we want to achieve the same benefits that all the randomized controlled trials exhibit? We have to mimic the similar protocols. And the way we get good outcomes in imaging in cardiology is by careful attention to all the steps in the process. The doctors have to do a good job interpreting the scans and have to do a good job communicating the results. But the key is before the doctors can get the scan, nurses and CT technologists have to do a great job of getting good image acquisition. If that doesn't occur, then there's no way the doctors can do a good job. So that's what we're going to focus on here for the next 25 minutes, is how to get the best image acquisition so we can get the best patient outcomes and get the best survival advantages for the patients that come to our hospitals. Now, I'm going to give you a few bottom line slides and then show you a little bit of data. This has been well studied. We've been doing cardiac CT now at Sentara Heart Hospital for 14 years. And I want to explain why we need to give beta blockers and nitroglycerin before cardiac CT so everybody understands. And the most well-studied drug is metoprolol. We use metoprolol for outpatients coming to the cardiac CT scanner, and studies over 14 years now have shown that it's safe, and you can use doses from 12.5 up to 300 milligrams. Okay, now I've never prescribed 300, but I have prescribed 200 at a time or 100 at a time, and the most common dose to give is actually 100 milligrams at a time. So I think good nurses are careful with doses, and they smartly want to use low doses in the protocol, but with time, comfort, and understanding of the data, you should feel more comfortable giving 100 milligrams because that is the average. People can get 200, and in the studies, people were given even 300. So what you should expect is the heart rate to go down by 1 beat per minute for every 10 milligrams of metoprolol. That's a rough rule of thumb. So if you give a patient 100 milligrams of metoprolol, you should expect their heart rate to go down by maybe 10 beats per minute. And the blood pressure lowering from metoprolol is very mild. Most cardiologists never use metoprolol in the office setting to reduce anybody's blood pressure because it's very weak. The most blood pressure we'll see reduced, even with 100 milligrams of metoprolol, is maybe 5 to 10 millimeters of mercury, which is not a lot of blood pressure reduction at all. The second workhorse after PO metoprolol is IV metoprolol. And we generally prescribe 5 milligrams up to 40 milligrams, but studies in cardiac CT have used all the way up to 70 milligrams safely. So when we're giving people up to 40 milligrams of low pressure, understand that's still half what people give in the studies and are still safe. And you should see the same degree of heart rate reduction from IV metoprolol that you see from PO low pressure, roughly 1 beat per minute for every 10 milligrams of metoprolol. The advantage of IV, of course, is it's fast onset and fast offset. But if you have to use 40 of it, you're going to give 5 milligrams at a time. That's 8 doses every 5 minutes. So it's a lot. That's why the workhorse is PO low pressure, because you can give much more higher doses and it's sustained. But we generally do top people off with IV, or if we need to get their heart rate reduced faster than normal, we can use IV or add a little bit to PO if we underdose them and then they get close to the CT scanner and need more. We also have to give everybody sublingual nitro. All cardiac CTs have been validated using 2 sprays of sublingual nitro, and that's because we need the nitroglycerin not only to dilate the coronaries, but also to drive contrast into the branch vessels, into the diags and into the OMs. We really don't see those branch vessels well unless we give patients nitroglycerin. So cardiac CT requires 2 sprays of nitroglycerin 4 minutes before the CT scan. And we can modify that in the emergency department by using nitro paste. And we can also combine sublingual nitro with nitro paste. I've even done a cardiac CT on a nitro drip before, but we're not going to get fancy. So modifications for the ER patients are basically 2 things. Number 1, we start giving the low pressure metoprolol in the ER to achieve the heart rate near 60 and then transport to the scanner. And that just keeps the patient flow working well, and it doesn't line up a number of stretchers in the advanced imaging centers near the scanner. We can also add PRN IV metoprolol in the ER setting, the same way we do in the outpatients, 5 milligrams to 40 milligrams. And remember, it's faster onset and offset, and it's safe to combine PO metoprolol with IV metoprolol. It's safe to combine metoprolol with Coreg if the patient's on chronic Coreg. The other modification in the ER, we can use nitro paste. So we can put 1/2 inch of nitro paste on the patient 60 minutes before the scan, and then take it off after the scan is over. Either take it off on the CT table or take it off when they get back to the ER. And again, if we think their blood pressure is borderline, we can always use sublingual nitro 2 sprays at the CT scanner, which is the standard for outpatients. There are some 3rd-line agents to think about. If you have given all the doses of metoprolol you think you can give, which would mean basically 100 to 200 of PO low pressure, 40 milligrams of IV, and you're still not there, then consider the patient's anxiety. If some patients are so anxious that no low pressure is going to reduce their heart rate, then a little bit of Valium goes a long way as an anxiolytic. There's 4th-line agents that we seldom get to, and I'm just going to mention them because they are stocked in the Pyxis, in the AIC, but I don't think they're stocked in the ER, and that's Ivabridine, which is a nice drug that reduces the heart rate without reducing the blood pressure. And this is most commonly used in Europe, but we have it. It's used in heart failure patients safely. It reduces the heart rate without reducing the blood pressure, and it comes in a PO 10 milligram. And the final drug that we rarely try to use is diltiazem IV will reduce the heart rate, but it tends to cause more blood pressure reduction. So we try to use it as a 4th-line agent after we've tried PO low pressure, IV low pressure, and considered the patient for an anxiolytic like Valium. Then I probably use Ivabridine, and then finally Dilt is sort of the last one. Now, it's different if the patient's hypertensive. If they're coming in with a blood pressure of 170 and we're going to do a cardiac CT, then maybe we start with Dilt because we'll purposefully reduce their blood pressure more and treat their severe hypertension at the same time as reducing their heart rate. Now, why do we have to reduce the heart rate for coronary CT? Doctors sometimes don't tell staff why, but this is why. If you do a good job as as a nurse and CT tech and get the heart rate down, then we can look at that RCA and see clear pictures of it. But that's like this. But if we don't, this is what we end up looking at. A blurred picture that you can barely see the RCA, and it's not diagnostic, and we can make mistakes and miss lesions. So that's why it's important for our nurses to get that heart rate down so that the angiogram is diagnostic when we do the CT. Otherwise, we're staring at something that has a lot of motion artifact, and it's very hard to tell what's going on, and we can miss lesions and make mistakes. So metoprolol PO followed by supplemental IV metoprolol is our workhorse. We've used it for 14 years. It's used all around the country in multiple institutions. It's safe, it's been well studied and effective. And we can combine it with chronic beta blockers in patients that are chronically on Coreg or even chronically on other metoprolol. It's safe to add on. Now, the other reason we have to use beta blockers to reduce the heart rate is because heart rate variability goes down when we use beta blockers. This is another artifact that we'll see that is suppressed by beta blockers. These slices don't line up, and when we're trying to read the RCA, we'll get these artifacts if we don't use beta blockers well. So that's a second benefit of beta blockers. A third benefit of beta blockers is that they tend to suppress ectopy. So if we have a bunch of PVCs and PACs, sometimes you can't suppress them, but sometimes a little bit more beta blocker will suppress them, and then we don't get these lines cutting across the heart on the CT scan, which drive us nuts when we try to interpret it. So a third benefit is suppression of ectopy. And then a fourth benefit is that by reducing the radiation, reducing the heart rate to 60 or 65, it allows our CT technologists on the table to reduce the radiation to the patient, and that makes the test more safe for more patients. The reason is by beta blocking patients down to a heart rate in the 60s, it allows the CT technologist to, in more patients, switch the scanner mode to what's called prospective gating. So prospective gating, we should remember for the CT technologist, is best used in patients that have a stable heart rate, which is more likely if you beta block the patient well. And patients who have a heart rate less than 60 is what I've always preached. And this allows us to use prospective triggering, scanning 60 to 85% of the RDR interval, which is called padding around the diastasis. And that suppresses, and that's best if the patient has no PVCs, no PACs, and no beat-to-beat heart rate variability, and certainly not atrial fibrillation. So prospective gating reduces the radiation dose. So the more our nurses beta block the patients down to a stable low heart rate, the more the CT technologist can reduce the radiation dose to the patient. Now, there's some patients where we use the old school retrospective gating. Those are patients who have a heart rate over 60 or have irregular heart rates, who are having PVCs, PACs, or beat-to-beat variability. And for them, we tell our technologists, scan them in late systole, 30%, all the way through diastasis with tube current modulation outside this range. Now, the techs have to know their scanner, and the techs know the scanner better than anybody. At some of our sites at Sentara, we have single source scanners, Rockingham and Williamsburg. And so for those sites, I think you would use prospective gating at a heart rate of 60 with a stable heart rate. But at sites at Sentara Heart, Virginia Beach, and Princess Anne, we have dual source scanners, and you can use prospective gating at a heart rate of 65 with a stable heart rate, not a table heart rate. That should be stable heart rate. Now, the goal is to lower the heart rate so that we can scan prospective in more patients and further minimize radiation dose. And the difference can be with prospective gating, you'll get away with only 4 to 6 millisieverts. That's less than a nuclear stress test, far less, versus 8 to 12, which is still less than a nuclear stress test, but obviously more than prospective. Remember, for the CT technologists, that we should tailor the KV setting to reduce the radiation further, and that's based on the BMI. In all patients less than, with a BMI less than 30, we want that KV down to 100. That's the standard of care in 2020. But if they're very large, BMI is over 40, 45, and certainly if they're over 50, then we should increase the KV to 140. At Children's Hospital at CHKD, when I scan the little ones, we'll routinely drop that KV to 80, and in a little baby, I'll drop it all the way to 70. Now, access is important. We really want 18 gauge IVs in the antecubital or proximal IV. That's because it allows us to achieve a 6 cc per second flow rate. And that makes our scan prettier and more diagnostic. We can get away with 20 gauges, but then our flow rates go down to 5 cc's usually, and there is a quality difference between a 5 cc flow rate and a 6 cc flow rate. So we really want to try to get 18 gauge IVs, although we can get away with a 20, but 18 is preferred because it allows us, our CT techs, to increase the flow rate to 6 cc's on the table, on the CT scanner, which is our ideal. Now let's talk about the drugs. Metoprolol is the standard because of demonstrated safety in congestive heart failure, in LV dysfunction, in COPD. You can give it to patients who have COPD, patients who are on oxygen. It's safe. It has low cost. It's 3 cents a pill. It's reliable. It's been used for 20 years for cardiac CT, and we see very little change in the blood pressure, maybe 10 millimeters, 5 to 10 millimeters with a 100 milligram dose. Remember, when you're, as a nurse, when you're looking at the patient and trying to decide on you're looking at their heart rate and trying to decide what the initial dose is or whether you should redose in 30 minutes, ask them to hold their breath and watch their monitor. If their heart rate goes down, as it does in some people, down 10 beats per minute, great, because that's probably what's going to happen when they are on the CT table. This is our protocol. For patients who have a heart rate of 55 to 60, we still give them 25 milligrams of low pressure, anticipating when they lay on the table and they get nitroglycerin, if it's sublingual, they're going to get a little more anxious, a little higher, and so we anticipate that. If they have a heart rate of 60, 65, we give them 50. It's not going to reduce their blood pressure, and it will improve the PACs that might occur, PVCs. It will also make their heart rate more steady and reduce artifacts, and it also makes it more likely that our CT techs will be able to switch to prospective gating to reduce their radiation. 100 milligrams is the most common dose in cardiac CT all over the country, but we're a little gentle. We start with 50, but it's safe to start with 100. It's safe to start with 150 in patients who have a heart rate of 75 to 80. It's safe to start at 200, and in the studies, people even start at 300, but we're not going crazy. But it's safe. And then we redose after 30 minutes with 50 milligrams as needed. So that's the other part of it. After 30 minutes, you're going to get that PO effect, and then it's time to redose with another PO dose if needed. Now, if you want to move fast or have to move fast, you can switch at that point to IV, and you'll get faster onset and offset. But but usually we just redose with PO rather than redose with IV. Now, in an emergency department and the patient is getting their scan the next morning, you should give the low pressure and nitroglycerin at 0630 if the first scan is at 7:30 in the morning, so about an hour before the first scan, if they're going to be the first scan of the day. Now, in studies of beta blockers for cardiac CT, the mean dose is 100 milligrams, okay? But the minimum dose, 12.5, and maximum doses are 300. So if you're giving somebody 100, you're still only giving them 30% of the max. If you're giving them 200, you're getting closer to the max, but you're still not at the max, which is 300. So that should give you some comfort if you give somebody 100. You're not going crazy. You're well below what the max is. The number of doses required to get a good cardiac CT, 85% of people need 1 dose, but some people, about 10%, need 2, and occasionally somebody needs 3. About 5% of patients are going to need 3 beta blocker doses, but most people get away with just 1 dose. Let's talk about IV low pressure. IV metoprolol. Doses between 20 milligrams and 70 milligrams are safe. These guys looked at almost 680 patients and showed that these were all safe doses. Lots of patients needed more than 20 milligrams of IV low pressure. So they graphed what was the IV dose that was required to get a good scan. And majority of patients needed 20 milligrams IV. Some people needed 30, some people needed 40, some patients needed 60, okay? And they even gave some people up to 70. But what they showed was this was safe. No patient needed atropine, no patient became hypotensive, no patient needed temporary pacing wires, none of that occurred. So safe to use low pressure in these doses. Let's talk about nitroglycerin. Nitroglycerin is important because it dilates the coronary. Here's a CT we did without nitroglycerin. Here's a CT because we forgot. And then here's a CT with nitroglycerin. Nitroglycerin makes the arteries larger and makes us calling the lesions when we read the scan more accurate. It also puts contrast into the branch vessels and allows us to see the diagonals and the obtuse marginal branches of the heart well. So nitroglycerin is very important. We use 2 sprays 4 minutes before the CT scan in the adult. At Children's Hospital, in the little ones, I use 1 spray. Remember, we don't give nitroglycerin to patients who have severe aortic stenosis, like TAVR patients, and we don't give nitroglycerin to patients that are taking Viagra, Cialis, or Levitra. Let's talk about emergency department caveats. There's basically 2 caveats. Remember, the quality standard in the emergency department for cardiac CT should be even higher than outpatient scans, and that means we need to give them beta blockers. Also remember that we are not making patients ischemic. We are not doing a stress test here. This is safer than stress testing because we're giving patients nitroglycerin and beta blockers. That is safer than stress testing if the patient has coronary disease, okay? And in the emergency department setting, patient selection is appropriate. Because of the safety of cardiac CT over stress testing, we can do more patients safely, patients who have symptoms that might be coronary, patients that have minor EKG abnormalities, patients that might have a borderline troponin. Those are safe to do, okay? And so that's the heart CT pathway adds a safety level for the patient, at the same time, a survival advantage if we do it well. We still want to be sure that patients that should be going to the cath lab are going to the cath lab because we don't want them going to the CT scanner, getting contrast, and then having to go to the cath lab. So that's the key medical decision-making for the docs. Modifications for the ED setting are 2. Number 1, we can avoid giving sublingual nitro on the CT scanner, for example, after 4 o'clock if there's no nurse, to spray nitroglycerin by using nitropaste, ½ inch before CT scanning, placed on the chest in the ER and then removed after the CT cardiac. If a patient is in ER obs overnight, then I don't think we should give their nitroglycerin all night long and give them a headache all night long. Not everybody gets a headache, but we can do it. It's safe to put nitro paste on at night and have the patient wear nitro paste all night. But it probably makes more sense just to put the nitro paste on 60 minutes before the cardiac scan, send them over to the scanner, scan them, and then take it off. The other modification, of course, is we start the metoprolol, PO or IV in the ER so they can come to the scanner ready to scan and return. Nitropaste is in the heart pathway ED order set now to apply 1/2 inch 60 minutes before the scan and removed once the scan is complete. Once in a while, we're going to have a patient who has a systolic blood pressure of 95, okay? And that's a patient that will be appropriately leery of putting nitropaste on. And so those are patients we can go the old pathway, which is sublingual nitro, 2 sprays on the CT table 5 minutes before contrast injection, which we do every day in the outpatients. However, that would have to be given by a nurse. And so that would limit us after 4 or 5 o'clock if there's no nurse around to spray nitroglycerin. Let's talk about Ivabridine quickly. It's a new drug. It's been around for probably 5-6 years. We use it in inappropriate sinus tachycardia, and you can combine it with beta blockers, with PO low pressor. It's probably our third line agent. It's PO in the United States. In Europe, it comes IV. And it reduces the heart rate without reducing the blood pressure, and we usually give it in a 10 milligram single dose. And we don't see any change in blood pressure from it. And it reduces the heart rate further. It's not in all the Pyxis, it's in the AIC Pyxis. So if usually this is going to be, it's not on an order set, it's something that we will give an order ad hoc after we've tried everything else. But some sites just start with it right up front. So it's safe, and it can be used as a third line, but it's a little expensive. It's about $3. So we don't go to it right away. And fourth line is DILT. DILT has been well studied. It's safe as well, but it does cause more reduction in blood pressure than low pressure, so we save it as our last resort. In this study, they used DILT. Patients were coming in with heart rates of about 73, and they went straight to DILT and reduced their heart rate into 60 range. And they saw a little more blood pressure reduction, just like when we give anybody a DILT bolus in the IV on the floor in telemetry or in the ER, we tend to see more blood pressure reduction from DILT than anything else. So how are the benefits achieved in all the trials in cardiac CT? They're achieved because we work as a team. The doctors have to do a good job interpreting the results, but the nurses and CT techs have to do a good job doing an image acquisition, or the doctors can't do their job well. And we won't get our patients and neighbors who come to the hospital the benefits that are seen in all the clinical trials in cardiac CT. Okay, that's my talk for today. This is our team at IHS. A lot of you have interacted with us over the phone, but I wanted to put some faces to the docs that you're interacting with. And if you ever need to email any of us, all of us on our website, our emails are right here. So every doctor's email is listed right here, and you can just click on it and email directly just by going to our website. So I wanted to open up the Zoom here for discussions from anybody about scenarios or issues that you might have in acquisition. There's a lot of different scenarios. Basically, every patient that we see clinically is a different patient scenario, but I want our nurses and techs to have a chance to ask some questions.
Dr. Basine?
Yes.
The Ivabridine, what is the time of onset on that, and how far off from the scan do you give it?
It's about like metoprolol. Usually you give a PO dose 30 minutes before the scan. 10 milligrams, reduces the heart rate. It acts solely at the sinus node, reduces the heart rate by acting on the sinus node. There's no effect on the AV node. There's no effect on blood pressure.
Thank you.
Hey, Dr. Basine, it's TJ. The pace for the ER, the nitro paste, after 60 minutes, what's the half-life of that? Like, how long do we have to, like, if we don't make it in that hour timeline, how long does that last?
Paste lasts, yes. Oh, you mean once it's placed, it will keep giving nitroglycerin. It doesn't wear off like sublingual. It'll be, as long as it's on, it's going to deliver medication.
Okay, sorry, just to clarify, full effectiveness of the nitro paste doesn't occur until 60 minutes after it's placed. But then after 60 minutes, we have an indefinite amount of time where it is actually active in the patient.
Once the paste is on the chest, it will continue to be absorbed through the skin and be given in the patient. That's why if they put the nitro paste on at midnight on the patient, when you scan them the next morning, nitro paste is still being slowly delivered.
Okay, so just we had a patient that came down from the floor a couple of weeks ago for a coronary CT. He'd actually been in the hospital for about 36 hours. He had the nitro paste stuck in his armpit because nobody ever actually removed it from the time he was in the ER. So had it still been in contact with his skin, would it have been useful at all?
Yes. If nitro paste is on the skin surface, even if it's in his armpit, it will be delivering. It will be absorbed through the skin and be delivered. The problem with paste, but obviously, like you're saying, if the paste has been rubbed off or it's in some crazy place, it's not going to be as reliable.
Okay.
So in that setting, you know, if it's during the day and you have a nurse, I would probably spray nitro in that patient. Give them 2 sprays. You can combine, even if they have nitro paste on, you can still spray 2 nitro.
So what's our upper limit of nitro dose?
There's no upper limit. There's no upper limit. We give, as long as the blood pressure is okay, you can give nitroglycerin. Remember, in the ICU setting, we use IV nitro and we dial it up to whatever it takes. 120, 150, 200 micrograms per minute of nitroglycerin. There's no upper limit that causes problems. You're limited by the blood pressure only.
Okay.
Nitroglycerin is very safe.
Thank you.
Anybody else? Okay, well, I hope this was helpful. We'll send a cloud link. If you guys want the slides, I'll send you the slides as a reference as well. And I hope everybody has a good day.
Hey, Mo, I have one question. It's Nirav.
Sure.
For these triple rule-out scans that are going to get done through the ERs, where one of the concerns is pulmonary embolism, is nitro actually safe to give in that situation, or is that something we hold off and do a flash scan first?
No, it's still safe because you don't want to scan somebody with contrast and then give them nitroglycerin. You have to give them nitroglycerin ahead of time. Yeah.
Right.
Okay. Okay, everybody, have a good day. Be safe.
Thank you.